So, hello and welcome everyone. I am Jamal Bleik, Chairman of Ophthalmology of the Ophthalmology Department at LAU, the Lebanese American University in Beirut, Lebanon. I am delighted and very happy to see so many attendees from all over the world. Around 80 cities are joining us today for this interesting webinar on pediatric neuro-ophthalmology. And I want to thank all the participants for their time. They took out time for us today to join us. This webinar, Pediatric Neuro-Ophthalmology, is the result of a joint effort between the Ophthalmology Department at the CME office of LAU, the Lebanese American University, and the International Pediatric Ophthalmology and Strabismus Council. And I want to thank both organizations for the great effort that has been put in that. Special thanks, of course, to Dr. Jaafar, my friend, to Dr. Ghannam from LEU and their teams who did tremendous effort in getting this all together. I also want to thank MIACO, the leadership and the board of MIACO, the Middle East and Africa Council of Ophthalmology, and the Lebanese Ophthalmological Society. They endorsed our event and they promoted our event today. And of course, my opening remark would be missing if I don't thank the speakers who were very kind to give us their time and their knowledge and joined us today. Finally, I would like to introduce Dr. Farouk Orgey, President of IPOSC, the International Pediatric Ophthalmology and Strabismus Council, who was kind to be with us today, and he's willing to welcome you all with us today. Farouk, the floor is yours.
Oh, thank you, Dr. Bleik, and again, it's a pleasure. And on behalf of the International Pediatric Ophthalmology and Strabismus Council, I also would like to welcome you all the participants joining from all around the world, to our monthly joint webinar series. And we have a star cadre of the speakers and moderators. And without further ado, while I would like to thank again the Lebanese American University for co-hosting and organizing this webinar, as well as the Lebanese Ophthalmological Society and MIACO for endorsing this session. And I will quickly want to hand it over to Dr. Jaafar, because I know we are all eager to hear from all the speakers. Again, thanks for having us, and thanks for being with us.
Thank you very much, Jamal, and thank you, Dr. Orgey, for all what you do and for what IPOSC is doing. I am Mohamad Jaafar. I am honored to serve as the chairman of the advisory board of IPOSC. I also serve as a member of the International Strabismological Association. I have been on the board of IPOSC and the Children's Eye Foundation. I'm presently the Weinstein Chair of...
Jamal, I'm happy to get started.
Okay, so let me then introduce Dr. Jane Edmond. Dr. Jane, who is professor and chair Department of Ophthalmology at Dell Medical School, University of Texas at Austin. And she's director of the Mitchell and Shannon Wong Eye Institute. Jane is a very old friend of mine. She's not old, I'm old. So I'm very happy to have her here. We tried to get her to Beirut several times. Now virtually she's here. Please, Jane, she will start the first presentation, and we are very glad to have you with us.
Thank you, Jamal, for that lovely introduction. And yes, we've known each other over 33 years, so it's great to see you virtually. Hopefully someday soon face-to-face. I thank the meeting organizers for having me. So let me share my screen. Can everyone see my screen?
Yes, we do.
Okay, great. So we'll go to present mode and choose slideshow. All righty. Look okay?
Yes, please go ahead, Jane.
Excellent. So thank you to the meeting organizers. Mohamad Jaafar and Jamal Bleik for inviting me and the other participants in this great pediatric neuro-ophthalmology webinar. So Mohamad asked me to speak on acute incomitant and comitant esotropia. My slides are not advancing. Let me figure out why. Here we go. No financial disclosures. So acute incomitant esotropia, this is easy. We all know how to make this diagnosis. Here we have a patient that presents to us with a left face turn where he is orthotropic, but in forced primary, the patient has 16 ET at distance and 8 at near, and he has no refractive error. He's ortho in right gaze, and in left gaze, he has a little left lateral rectus underaction and 25 ET. This is not a difficult diagnosis. This is a 6th nerve palsy. And what is, he has an abduction deficit and it's incomitant. And very importantly, as a characteristic of 6th nerve underaction or a 6th nerve palsy is the distance esotropia is greater than the near esotropia. So what about a workup? Do you do neuroimaging? Well, for acute incomitant esotropia, that is a 6th nerve palsy, and a workup is usually indicated. There are a few exceptions, and we all know about these. Post-viral or post-vaccination 6th nerve palsy with no other symptoms, a patient after neurosurgical intervention or major head trauma, that probably doesn't require any further workup. But what about the more troubling acute comitant esotropia or ACE? So in older literature, there are associations and etiologies, breakdown of fusion, decompensated esophoria or microtropia. Some of that could be occlusion related. Also, another factor in breakdown of fusion is anisometropia. It's also been described in patients who are myopic, 20-year-olds with moderate myopia, and also older individuals with the heavy eye syndrome. And we've all been seeing a lot of age-related divergence insufficiency esotropia in our elderly patients, and that can have an acute onset, although it usually is more slow to intermittent and then becomes constant. And what about the troubling comitized 6th nerve palsy? How quickly does comitance develop? And does the distance esotropia still greater than the near esotropia? Does that characteristic of a 6th nerve palsy persist? In my opinion, yes. There are new associations in the literature, excessive near work, smartphone use. I've seen 2 patients with this as it felt to be the contributing factor to their acute comitant ET. Idiopathic, that's not really new. Is that acute decompensation of an esophoria? Could be. If there are no other factors involved and patients otherwise healthy, idiopathic is pretty common. Then there are the troubling and worrisome intracranial pathology. Brain tumors, pontine gliomas have been reported to cause ACE, cerebellar tumors as well, and also Arnold-Chiari malformation type 1. So how about a workup here? Neuroimaging, misspelled, sorry, indicated for acute comitant ET. Well, I will convince you, I hope, that it's usually benign, so usually no workup is necessary, but I'm pretty sure I'm going to need to convince you that most cases are benign and help you understand which patients have non-benign acute comitant ET and which need workup. So intracranial pathology, and I have the references at the end of my slide deck because I know this will be recorded. Intracranial pathology is rare in children with ACE. Dotan et al. In a poster at APOS reported on 20 healthy children with ACE. They had low hyperopia, no lateral rectus underaction, comitant obviously, no nystagmus or papilledema, no worrisome neurosymptoms, and the near esotropia was either greater or equal than the distance esotropia. And 19 out of 20 of those children obtained neuroimaging, all benign, all negative, all normal, and the diagnosis was benign ACE. One refused imaging but didn't have any symptoms after 2 years. So I'm thinking that the near ET greater or equal to the distance esotropia is reassuring. A second study, a larger group, 48 Buck and Bendig, 48 children with ACE They found 31% were accommodated VT, needed hyperopic glasses, 27 were decompensated ESA deviations, 19% were deemed idiopathic. What did not indicate whether they had MRI scans. 6 were related to monocular occlusion, and 6% were their ACE was due to previously diagnosed neurologic diseases. These are 3 patients, one with ataxia telangiectasia, one with optic neuritis and vision loss. And only 3 or 6% newly discovered intracranial pathology out of this entire group of 48 children. 15 children received no imaging, but in the long-term follow-up, they had no additional symptoms. 33 of the children obtained MRIs, and out of those 33 were the 3 with newly diagnosed intracranial pathology. One was a pontine glioma, which rapidly developed in Nystagmus in the weeks following, and headache and ataxia. The second was a patient with hydrocephalus and papilledema. I mean, that's an easy diagnosis, right? That goes straight to imaging. The third was a thalamic glioma with no need for intervention. But the patient had thalamic gliomas do not cause esotropia. They're nowhere near the 6th nerve. It's near the optic radiations. This patient had a history of fully accommodated esotropia, and maybe that was just a breakdown of a partially accommodated VT. So this study found that the most reliable indicator of intracranial pathology were neurologic symptoms or signs: headache, ataxia, papilledema, of course, in-gaze nystagmus, and very importantly, distance esotropia greater than near esotropia. That occurred in the pontine glioma and the patient with the hydrocephalus and papilledema. So on the flip side, intracranial pathology, the ones I've mentioned, Arnold-Chiari malformation 1, pontine and cerebellar tumors, how often does ACE occur in those conditions? Well, it's pretty rare. So Arnold-Chiari type 1 occurs in 3% of the population. This is a guess. We see it as pediatric neuro-ophthalmologists not infrequently. One study indicated, natural history study of Arnold-Chiari malformation 1 in children, 96% are asymptomatic. So there are definitely reports, and we know of them, of ACE being cured by Chiari decompression. But all of those kids, as I look through that literature, had additional neurologic symptoms. Here on the right is a study of 51 symptomatic children who obtained an MRI and had Arnold-Chiari type 1 diagnosed. So they were symptomatic, mostly of headache. And you can see on this list, none of them had ACE. That's 51 children. So what about pontine and cerebellar tumors? We're worried you're going to miss that. But the most common signs with pontine and cerebellar tumors are a 6th nerve palsy, incomitance, 7th nerve palsy, gaze palsy, long tract signs, hydrocephalus, papilledema, ataxia. And if they aren't present at the time, those symptoms are not present at the time of presentation, they will very soon develop. So my conclusion is, acute incomitant esotropia is a 6th nerve palsy, and a work is typically indicated. We know all about that. Acute comitant esotropia, most cases are not secondary to intracranial pathology. If you're not going to image, closely follow for the development of other signs and symptoms. And neuroimage children with abnormal eye exams or abnormal neuro histories or exams, including in-gaze nystagmus, papilledema, and very importantly, distance esotropia greater than near. And histories ask about this because in my early days, I've forgotten to ask about headache. Headache with cough and Valsalva is very suggestive of Arnold-Chiari malformation. And headache on awakening or in the middle of the night is suggestive of elevated intracranial pressure. Neck pain, it can be can occur in lieu of a headache. Also dizziness, ataxia, and a facial palsy. So here are the references. I won't go through those, and thank you very much.
So thank you, Jane, for a very informative presentation. I wanted to ask you something. If you decided to image, do we have any studies that tell us if scan versus MRI would yield different results, or would would have a different yield?
I'm sorry, Jamal, repeat the question for me. I was fiddling with my slides.
I was asking you, if you decided to image,
Yes.
do we have any information or data or studies that tell us that CT scan versus MRI can yield different results?
Yes. So all posterior fossa tumors are poorly imaged with CT scans. If you have a big tumor, you'll find it on a CT scan, but the preferred study of choice for illustrating posterior fossa contents and details of brain and brainstem, for Arnold Chiari would be an MRI, and also to remove the risk or the exposure to radiation for the child.
I see. And do you usually order the imaging directly, or you refer your patients to a pediatric neurologist first?
Oh no, I do it right away. If I am concerned in with any patient that there's intracranial pathology, I'm the one ordering it, and I'm the one making sure it's done in the time frame that I indicate, either urgently, within the next week or today.
Okay. Does anyone from our speakers or moderators want to ask Jane something? Sean, please.
Yeah, hi, Janie. Great job. Thank you. I still struggle sometimes with imaging for looking for a Chiari, even though there's no neuro-ophthalmologic signs. But this is a child or a young adult. They're just in that age group where don't expect acute Comitant esotropia to develop. You'd say it's a 12-year-old or a 20-year-old. They're not a -5 mild. They have a Comitant ET. I've seen it very rarely, and I just struggle with whether to image them or not. And I hate putting them to some of these people to sleep to image, or otherwise still getting the MRI in older people. Can you comment on what things influence you one way or the other? And I'm really only looking for a Chiari in those situations.
So Chiari malformation should have symptoms if it is to be clinically impactful, because most Chiaris in children are very asymptomatic, but their leading symptoms are headache, a tussive headache, a headache induced by coughing or a Valsalva, bowel and bladder issues, speech problems, ataxia, upper limb weakness. So without those symptoms or signs, you may not need to proceed with the MRI, but this is not a common condition. So I'm thinking that most people are going to proceed with MRI. But what are you going to do about that patient that just has ACE, a Chiari type 1? Would you rather have a posterior occipital decompression, or would you rather have a 35-minute bimedial rectus recession?
Yeah,
I'm voting the latter.
Yeah, my pediatric neurosurgeons won't operate for it. They say it doesn't cause it. These wasn't the cause of the symptoms, and they're not going to decompress them. So should I even bother looking? I hate to not look because I'm not going to treat, but that's what my struggle has been lately on this.
So, Sean, you're working with ethical and academic neurosurgeons. They all are not like that. So I was in a community where there was a group of pediatric neurosurgeons that decompressed every headache. So you have to be careful that the neurosurgeon you're working with.
I should agree with what Sean is saying. Our neurosurgeons at Children's in Washington are very, very hesitant to combine or associate the esotropia with the Chiari. Very, very, you really have to convince them. I think the signs and symptoms that you talked about, association with cough and headache, are really a very nice thing to know. Thank you.
Absolutely. Just one quick question from the attendees, because it's been posted in the chat box. How urgent after the presentation of esotropia would the MRI be warranted? How urgent it is?
So
this is our last question for Jenny, and then we'll proceed. Sorry.
If a patient has any of those neurologic signs or symptoms, I would obtain the imaging within 5 days.
Okay, that's great. I really thank you for this knowledgeable presentation, and we will proceed with our next presentation. Please, can we post that, the presentation, the PowerPoint presentation? Yes. So our next speaker is Dr. Gena Heidary, Director of the Pediatric Neuro-Ophthalmology Service and Fellowship Director of Ophthalmology and Strabismus in Boston Children's Hospital, and she's an assistant professor of ophthalmology at Harvard Medical School. Gena has a special interest to as if pediatric ophthalmology alone is not challenging enough. So she specializes in pediatric neuro-ophthalmology, and she's the director of the Consortium of Pediatric Ophthalmology. So we are ready to listen to you, and she will be talking about pediatric idiopathic intracranial hypertension. Gena, please.
Wonderful. Thank you so much, Dr. Bleik. Let me just see if I can advance my slide. IPOSC and LAU for this opportunity to contribute to the webinar today. I have been asked to give an update on pediatric idiopathic intracranial hypertension, and I'm really pleased to spend this morning or afternoon with dear friends and colleagues. I have no financial disclosures. So let's frame our discussion with a case. This is a 13-year-old boy who presented to the emergency room with about 3 weeks worth of headaches, for which he went to his pediatrician several times. And finally, when he began to report double vision, he was sent to our ER. On presentation, already his vision was fairly poor, 2200 in the right eye and 2080 in the left eye. He had evidence of optic nerve dysfunction with color vision deficit, and he also presented with a 6th nerve palsy. You can see here Goldman visual fields with characteristic findings of that occur in the presence of optic nerve edema, with generalized constriction of the visual fields in both eyes, as well as enlargement of the blind spot. And here you see the fundus photos showing really profound disc edema, 360 degrees, with blurring of the vessels, even a few cotton wool spots, and a few hemorrhages. So we sent him immediately to our emergency room for neuroimaging. At our institution, we do MRI as well as MRV of the head, both of which were essentially normal. He subsequently underwent lumbar puncture, which showed a markedly elevated intracranial pressure of 55 centimeters of water with normal CSF. So his diagnosis is idiopathic intracranial hypertension. He was treated with medical management initially, but continued to progress and ultimately had an optic nerve sheath fenestration, which we can talk about later. And his 4-month follow-up, his vision was already markedly improved, 20/25 in the right eye, 20/20 in the left eye. You can see some expansion of his visual fields with some residual nasal deficits characteristic of his optic atrophy and diffuse optic atrophy in both eyes. So what I'd like for us to focus on is what are the characteristics of pediatric presentation of IIH? What are the current diagnostic criteria, and how do we manage this condition? So the first is that we know about adults where we associate this condition with women of childbearing age who are obese. And this occurs in about 19 in 100,000 women of this characteristic. And probably in children, formal epidemiologic studies have not been undertaken, but one study suggested that it occurs in about 0.6 to 100,000 in children under the age of 18. Importantly, this condition has really two cohorts, if you will. So the cohort that's prepubertal, in those patients, there's an equal distribution between boys and girls, and there really isn't an association with obesity. So in this study from Laura Balser, when she was at Children's Hospital Philadelphia, they looked at 40 patients with IIH and found that in those who were prepubertal, there really was equal distribution, boys and girls. And as the children got older and older, then we found an enrichment for young girls who were overweight. Similarly, we contributed to a multi-center retrospective study of 233 cases of IIH. And you can see here, female patients are on the left and male patients are on the right. In the younger age group, there's an equal distribution between weight or BMI Z score, but with increasing age, the predominance was girls who were overweight. We look for symptoms of elevated intracranial pressure, position-dependent headaches, pulsatile tinnitus, transient visual obscurations, blurry vision, and diplopia. But importantly, many patients may present asymptomatically. So when we looked retrospectively at our cohort, we found about 21% of patients had no symptoms with the exception of optic nerve edema. And when we did an analysis of this group, they tended to be young, skinny boys. Signs of elevated intracranial pressure are similar to those we see in adults with decreased vision, visual field deficits, cranial neuropathy of 6, nerve palsy, and signs of optic nerve dysfunction. At our institution, we perform MRI of the brain in orbits as well as MRV of the head. And MRV we find to be important because at times papilledema or optic nerve edema can be associated with dural sinus thrombosis rather than IIH. And in this circumstance of dural sinus thrombosis, the treatment would be really distinct. So we want to make sure we don't miss those patients. We performed a case control study of 38 pediatric IIH patients compared with controls who were undergoing neuroimaging to see what are the radiographic characteristics. We want the MRI to be essentially normal, but there are some soft signs of elevated intracranial pressure. We found that the subarachnoid space diameter, which is shown here, can be enlarged, and we found that if the subarachnoid space diameter was greater than 5.2 millimeters, the sensitivity for elevated intracranial pressure was 87% and specificity 67%. We also see that patients may have flattening of the globe, protrusion of the optic nerve, empty sella turcica. So these are all soft signs of elevated intracranial pressure. We confirm the diagnosis through lumbar puncture, and importantly, the diagnostic criteria have evolved from a historic norm of an opening pressure of approximately 20 centimeters of water to greater than 28 centimeters of water if the lumbar puncture is done with sedation, or greater than 25 centimeters of water if the lumbar puncture was unsedated or if the patient was not obese. So this is an important paper that you should be familiar with, which really outlines the revised diagnostic criteria for this condition and outlines what we've talked about in the previous slides. For treatment, we favor ICP lowering medications. We start off with acetazolamide at the dosages indicated here, about 10 to 25 milligrams per kilo. It's very important. Children are exquisitely sensitive to diuretics, and so we monitor their blood chemistries. They almost consistently become acidotic, and so we often are repleting the bicarbonate. When relevant, weight loss is recommended. And when patients come in with a fulminant presentation, a very aggressive presentation, we may temporize them with a lumbar drain. In this study, in this case, we did an optic nerve sheath fenestration, which is fairly rare at our institution. And because of the morbidity associated with shunt and infection and shunt failure, our neurosurgeons are fairly hesitant to put in a shunt until we really maximize other treatment. Historically, this was considered to be a benign process. It was benign intracranial hypertension. And now we know that there's a potential for really profound vision loss. The initial case series describing this came out in the 1980s, and subsequently there have been multiple series that indicate that there can be vision loss at the level of legal blindness, visual field deficits, as well as optic atrophy. And one recent study suggested that puberty may be a risk factor for poor outcome. When I first started over a decade ago at Children's, we looked at a cohort of patients who had been treated prior to my start just to get a sense of how we were doing. We found 86 patients with this diagnosis who were predominantly girls who were obese. And at our institution, we found that 2% of these patients were legally blind at the end of their treatment. A quarter of them had permanent visual field deficits. 15% had optic atrophy. 14% underwent neurosurgery, and 14% recurred. So this has led to sort of the foundation of many questions that I think we would consider current and future directions on this topic. So the first is that we are contributing to a prospective natural history study of pediatric IIH that's going to be led by Grant Liu at Children's Hospital of Philadelphia. And I think this study is going to help us to understand many aspects of this condition. When do we use medical versus surgical therapy? What accounts for recurrence in IIH? What is the fundamental pathogenesis of this condition? Is this a condition of cerebral spinal fluid overproduction or decreased absorption? How do we factor in pubertal status? And finally, what tools are most effective in following our patients? We favor using fundus photography and optical coherence tomography, OCT, in order to quantify the optic nerve and follow it over time, in addition to doing vision and visual fields. But I think looking to utilize this prospectively will give us more insight into which biomarker predicts sort of risk factor for poor outcome. So in summary, IIH is a condition of elevated intracranial pressure with normal neural imaging and CSF constituents. It's important to recognize that in children who have not undergone puberty, boys can be affected and obesity is not a factor. The symptoms may be similar to those we see in adults, including headache, visual changes, diplopia, and pulsatile tinnitus, but children may also present asymptomatically. So in those situations, if you've done your evaluation for pseudopapilledema, for example, you've looked for optic nerve head-drusen and there's none, it's important to work up the asymptomatic patients because this may be IIH. And the reason to do a thorough evaluation is because there's the potential for profound vision loss. So we have to diagnose promptly and treat appropriately. Thanks so much.
Thank you very much, Gena, for the great topic and the great talk. We have some of the questions. Someone asked if there is any association with ulcerative colitis, because I think they meant if there's any association with any inflammatory conditions in general. They had a patient with that.
Thank you for that question. So I'm not specifically familiar with an association with ulcerative colitis. We do know that there have been cases with steroid treatment and steroid withdrawal that then may precipitate this condition. So I wonder if there were sort of multiple steps in between the diagnosis of UC and the elevated intracranial pressure. I don't know that there's a direct relationship between the two, but it may be medication related.
Okay, there's another question whether you would consider VEP in kids to monitor their vision if you cannot check for vision on those, and if there are any signs which are more likely to be associated with irreversible vision loss.
Thank you for these questions. So I think there have been, so first, I think this is a condition that isn't typical to occur in very young children. And so it's more common than not that we're able to get some visual acuity assessment. So I haven't typically used VEPs in this circumstance. I think that there are studies, I think Dr. Heidary has contributed to this literature looking at ganglion cell layer on OCT. And when we see signs of GCL thinning, this may be associated with a poor visual outcome. I think we, for us, our most successful tool has been quantification of the optic nerve using OCT. And in the age range where most of our children present, we find that they're able to participate in OCT. I think when we're finding very young children who are being diagnosed with this, it's important to sort of explore other conditions not idiopathic. So for example, we've had a couple of patients who were undiagnosed with craniosynostosis who presented in younger ages and then with papilledema and were sort of presumed idiopathic. But when we evaluated them further, we found that they had an underlying condition that contributed to elevated intracranial pressure. So I think when you're making this diagnosis in very, very young children, it's worthwhile to explore that this may not be idiopathic.
Okay. And what do you consider as high pressure in kids?
Yes, so the New England Journal study that I alluded to from Avery and his colleagues, I think it came out in 2010, is an important study. So they looked prospectively at 197 patients who were undergoing spinal tap between the ages of 1 and 18. And when they sort of operationally defined 90th percentile, so greater than the 90th percentile was elevated, they found that the threshold was 28 centimeters of water if the patient had a sedated LP, and 25 centimeters of water if the patient was not sedated and was not obese, because sedation can sometimes cause the pressure to go up a little bit. So we use 28 for sedated and 25 for unsedated. That being said, of course, you know, after this paper came out, there were many studies that suggested we can't be completely beholden to just the number. So if the clinical context, you know, let's say it's 23 centimeters of water and the clinical context really supports this diagnosis, then we need to consider treatment. But I think historically, there are patients who, you know, had an opening pressure of 18 centimeters of water, and that probably wasn't IIH.
We have lots of questions.
Okay, good.
So one of the questions, how long do you wait until considering optic nerve sheath fenestration in kids?
Yes, thank you. So this was an unusual circumstance. So I've been at Children's Hospital now for 11 years. We've done optic nerve sheath fenestration twice in 11 years. I think it's very institution dependent. I think the largest study of optic nerve sheath fenestration came from Dr. Buckley at Duke. And so we typically don't offer it because I don't think that it necessarily treats the systemic findings of headache and so on. I think we offered it in this patient because he was progressing rapidly. Neurosurgery didn't feel comfortable to put in a shunt. And at that time, we had not been doing a lumbar drain as a temporizing measure. Now, I think we would go to lumbar drain quickly, which we've done in a number of our fulminant cases as they're getting sort of stabilized on acetazolamide. And that's been a very effective way of managing these aggressive cases.
Okay, I think we're gonna have to move on. Maybe if we have time at the end, we'll take more questions.
Okay, thank you so much.
Thank you. Now I would like to introduce our next speaker, Dr. Sean Donahue, that's from Sam and Dorothea Coleman Chair in Ophthalmology. He's a professor of ophthalmology, neurology, and pediatrics, and the vice chair for clinical affairs at the Department of Ophthalmology and Visual Sciences at Vanderbilt University Medical Center in Nashville, Tennessee. The floor is yours.
Thank you. I appreciate the kind introduction. There we go. Get my screen share here. Thank you. I appreciate that introduction. I wish I could be in Lebanon with y'all, but that won't happen this year. So maybe Farouk and Mohamad, we can figure out a way to make that happen. I certainly would love to be in that country and see it at some point. I was going to talk today briefly about infantile nystagmus, the evaluation and the treatment of patients with it. I have no relevant conflicts of interest. These patients really present as part of what I think of the spectrum of the child who's a visually impaired child or the visually impaired infant. And so really the workup of nystagmus is part of the workup and the management of visually impaired infant. These children present with the child and the parents saying, either my child can't see, or my child has nystagmus, or my child has something wrong with the eye, whether it be a cataract or whether it be some other type of media opacity. When I see these children, I like to take a look at how their overall visual function is. And when I look at the history and their examination, things I ask about, whether or not there's prematurity, other congenital abnormalities, whether or not there was something at the time, usually perinatally or immediately postnatally, of some type of devastating neurologic accident. And then whether or not there's nystagmus and whether or not there's a healthy afferent visual system helps me in that regard. My differential diagnosis then for that child with visual impairment depends on whether there is nystagmus and depends on whether the afferent pathways are normal or not structurally. So when I evaluate that infant with nystagmus, I don't like to use the terms sensory or motor. Motor nystagmus is really no different than sensory nystagmus in its waveform, and it doesn't indicate that there isn't an afferent defect. So let's use the term infantile nystagmus syndrome. I'm going to try to use that the rest of the time and distinguish that from latent or manifest latent nystagmus, which is now called fusion maldevelopment syndrome. What we have to do is rule out structural abnormalities in the eyes, evaluate for high refractive error, and then treat those things. The workup becomes, do we image, do we get electrophysiologic testing, or do we some type of genetic testing? With children who have nystagmus and structurally abnormal eyes, typically there is a reason for the structural abnormality, and you'll be able to see that on your exam. Either there's bilateral medial opacities. If there is, work up for bilateral congenital cataracts. Bilateral optic nerve abnormalities. You need to work up for endocrine dysfunction. And this is one of those classic papers that I tell the residents and fellows that needs to be committed to your brain, and you need to tell the pediatric endocrinologist that you work with about it. This is a series of 5 patients reported by Mike Brodsky who had sudden death associated with septo-optic dysplasia. And the reason they had sudden death is they couldn't get cortisol, adequate cortisol responses during periods of cortisol insufficiency, like mild infection. One of them died actually during the period of stress after the MRI scan. And so the child who has bilateral optic nerve hyperplasia, especially the child who has associated neonatal jaundice or neonatal hypoglycemia, absolutely must have endocrinology evaluation with the cortisol stimulation test to rule out cortisol insufficiency. We also picked up 3 patients who presented with other signs of pituitary insufficiency, diabetes insipidus, which is more posterior pituitary, but repeated severe infection, again, because you have the anterior pituitary cortisol insufficiency in patients with optic nerve hypoplasia. So these were 3 patients that presented into our hospital with nystagmus, but they were admitted for repeat infection and for DI, and it turns out that the ophthalmologist was the one who was able to put everything together here. Well, how do we treat this? Well, in congenital cataracts, if that's what the media opacity is, clear the visual axis, use the appropriate refractive correction, monitor for glaucoma, of course, and then follow for amblyopia and follow for strabismus. So that's nystagmus with structurally abnormal eyes. What about nystagmus with structurally normal eyes? Oftentimes that's retinal pathology, and it may not be observable when you first examine the child. Ask about consanguinity. The refractive error is often to high hypermetropias associated with Leber's congenital amaurosis. High levels of astigmatism may be associated with albinism. I used to get an ERG at 1 year of age, and now I'm moving much more towards genetic testing, and I'll spend the next couple minutes talking about that. The nystagmus, the differential diagnosis of nystagmus with normal ocular structures, I tend to think of as the 4 A's. So there's 4 A's, I say the 4 A's and the B of nystagmus with normal afferent structures. So albinism, aniridia, Leber's congenital amaurosis, and achromatopsia. And the B is congenital stationary night blindness. So those 5 things are the majority of things that produce nystagmus, infantile nystagmus, in the setting of normal afferent pathways. Prematurity can do it as well. This is what we used to do in the past, and I was thinking this morning on my run that I like to teach the residents about this, but that's probably becoming a thing of the past because of the genetic testing. But what we do with the ERG is get a scotopic dark-adapted dim flash, a dark-adapted bright flash, and then a 30 hertz flicker. LCA, of course, is going to have no response at all. Achromatopsia, you'll have a reasonable dark-adapted dim and dark-adapted bright flash, but because there's poor cone function, you won't get the 30 hertz flicker. Congenital stationary night blindness, no dark-adapted dim flash, a normal flicker, and this is that inverted V wave or inverted, called a negative V wave that is always on the board examinations, compared to the control with a normal, healthy, dark adapted dim flash, a dark adapted bright flash, and a normal 30 hertz flicker. That's really the past, and it's probably been a year since I've gotten an ERG. But you can use the ERG results here to try to make that classification. About 5 years ago, this paper came out, which really made me start thinking we needed to do some type of genetic sequencing or genetic testing on these patients. The problem with next generation sequencing is we didn't have it. It was very expensive and it was very hard to do. So I was hoping that something would come up. And in fact, it has. I have no financial interest in this, but this is a genetic test that's free, sponsored by Spark Therapeutics through Invitae. And they test, it says 250 genes associated with inherited diseases. It's now 293. And they have both a buccal swab that you can swab the child's cheek, or you can have the child spit into a little vial and send it, and it tests that. And I found that to be really very helpful. I've done it about 24 times now, and probably 75 to 80% of the time, some known gene is identified that's associated with the development of infantile nystagmus syndrome. And this is one that I tested a few months ago who had X-linked infantile nystagmus. And I love having that diagnosis because now I can look at the literature and say, for that particular gene, this is what I expect for the phenotype. And that's very reassuring for the parents. And then it can also help with our genetic counseling that we send to genetics or the pediatrician to do that. I want to spend the next few minutes talking about treatment, and mainly the surgical treatment of patients with infantile nystagmus. Many of them will have a null point. They'll have a null point either with associated strabismus or without associated strabismus. Kestenbaum first described symmetric surgery, 13 millimeters of total surgery in each eye to move the eyes into the direction of the head position. And we review with UC Zhang and Jim Law 200 of our patients who had Kestenbaum procedures, either adapted for strabismus or just a standard Kestenbaum surgery for the results. And this is a series that was in the AJO in the last couple of years. We use standard surgical planning. So this is a child who has a face turned to the left. You can see him looking at this object of regard. The null is in right gaze. So to treat that, we move the eyes in the direction of the face turn. Another way to think of this is this right eye is relatively exotropic compared to primary position. The left eye is relatively esotropic. So we want to do XT surgery on the right eye and ET surgery on the left eye. And then we augment based upon the angle of the face turn. For under 30 degrees, I do a 40% augmentation. For over 30 degrees, I do a 60% augmentation. So this series is based upon 131 of these 200 patients that had the standard augmentation because they had no associated strabismus. So up to 30 degrees, 40% augmentation. Up to, or more than 30 degrees, a 60% augmentation. And oftentimes these are multiplanar. In other words, they may have a tilt or a chin up and down. The vast majority of those, if there's a significant horizontal plane face turn, if you operate for the horizontal face turn, you can get rid of most of the face turn, and you don't need to treat the tilt or a chin up and down. This is a Kaplan-Meier survival estimate, and you can see at 8 to 10 years out, almost 3/4 of them are still straight. This is over and under correction rates. Under correction about 7%. Overcorrection initially a little higher, and then a few reoperations, but generally they tend to do quite well. In the last couple minutes, I'm going to talk very briefly about how you manage patients who have that abnormal head position and associated with a horizontal strabismus. Standard Kestenbaum surgery doesn't alter that angle of strabismus, and the fixating eye here drives the head position. So you have to think about wanting to operate on the fixating eye to be able to treat it. You alter your surgical numbers in one or both eyes to correct the head position and the face turn with one strabismus surgery. And again, UC put this together. Derek Holt was a fellow a few years ago and really came up with a nice criteria where he defined concordant or discordant strabismus associated with an abnormal head position. Surgery for the abnormal head position on the fixating eye would decrease the angle of strabismus in a concordant case, whereas in a discordant case, if you operate on the fixating eye, it would worsen the angle of strabismus. This is briefly an example, first, of the patient with no strabismus here. The second one, a concordant strabismus fixating in the left eye, operating on the left eye, would help the strabismus and the face turn. Whereas a discordant strabismus, if you operate for the abnormal head position here on this fixating left eye, you're going to worsen the head position. So concordant strabismus, you have a face turn to the left, fixating with the left eye in adduction. Your right eye here is esotropic. We're going to do surgery on the left eye to improve the esotropia, a full augmentation on the left eye, but then decrease the surgery in the right eye to be able to account for the strabismus. I put a prism over the fixating eye to estimate the postoperative alignment in the non-fixating eye. The discordant strabismus is much more problematic in our series. This child, again, face turned to the left, fixates with the left eye in adduction. The problem is the right eye is exotropic. So if we operate for the head position, it worsens the exotropia. So here you have to do more surgery than expected on the non-fixating eye. So you do maximum 60% augmentation in the non-fixating eye, and then back down and do the recession only in the fixating eye. So surgical plan, and I'm going to stop here. The concordant surgery, you do a standard augmentation in the fixating eye and decrease the amount in the fellow eye. But in the discordant case, you operate for as much as you can in the in the fixating eye, and then you decrease the amount in the non-fixating eye. Thank you. I appreciate your attention.
Okay, great presentation. Thank you, Sean. Very informative. I have a few questions from the audience. So first one is, could nystagmus present late in a patient with retinitis pigmentosa?
You said, can nystagmus present late in patients with retinitis pigmentosa?
Yes, this is the question.
I'm going to lump retinitis pigmentosa into a number of different inherited retinal diseases. With early onset retinitis pigmentosa being LCA, I've seen Lawrence-Boone-Barrett beetle, which is a type of an acquired retinitis pigmentosa, present relatively early with nystagmus. And then in older age individuals with a classic RP, you don't tend to see it because they're older and they're adults. So rather than think about the type of the disease, I'd rather think about the age of onset. And all afferent pathology, whether it be acquired or inherited, if the vision loss is present within the first year or so of birth, they develop nystagmus. If it's present after the age of 4 or 5, they don't get nystagmus. And somewhere in between the age of 1 and 5, they sometimes do and they sometimes don't. So that child who comes in with an acquired nystagmus at the age of 2 or 3 and evidence of afferent visual system dysfunction, you definitely have to worry about some type of inherited retinal disease.
Okay, another question. When do I have to do brain imaging in an infant with nystagmus?
So I do brain imaging when I am worried about bilateral afferent pathway dysfunction. So craniopharyngiomas, primarily chiasmal gliomas are going to be the two biggest things. You could presumably get it from optic atrophy from posterior fossa malignancies, although that would be pretty rare. Children who have craniopharyngiomas, have bilateral optic pathway gliomas, are going to have pupillary evidence of abnormalities. And so you will either see an afferent pupillary defect, or you'll see relatively amerotic pupils with light nerve dissociation, or you will see optic atrophy. In the absence of those three things, I don't typically image because the amount of afferent visual system dysfunction that you need to produce nystagmus is much greater than you would be able to get and still have no optic atrophy, no amaurotic pupil, and no relative afferent pupil. So I'm fairly conservative in those. I don't image first. I would image only if I was concerned about the afferent function, and I'd rule out inherited retinal diseases as well.
Okay, do you do large recessions if the patient does not have an abnormal head posture?
Yeah,
large recessions of all muscles if the patient has no compensatory head posture.
Yeah, that's a great question, and it's a really very controversial question. Just to give a little bit more background on that, for patients who have a face turn, when the face turn's always in the same direction, you do the standard Keston ball, which is a recess reset in both eyes. But some patients either have no abnormal head position or worse, an alternating head position, and they may have congenital periodic alternating nystagmus. Those are really challenging to deal with. People have talked about doing large recessions of both horizontal rectus muscles, 8 to 9 millimeters on the medial, 10 to 11 millimeters on the lateral. I have done that in the rare occasion. I don't like to do it. I did one a few weeks ago for a patient who had congenital periodic alternating nystagmus. It doesn't typically get rid of the nystagmus. It does blunt it to some extent. It doesn't always get rid of the face turn. And it typically doesn't improve the vision a lot. So I'm relatively hesitant to do it. I know it's been described in the literature, but I think you have to have a long discussion with the parents about what the expectation is. And if they think they're going to get a marked improvement in visual function from this, I think you need to reset the expectations. I know Rich Hurdle and others have provided really nice evidence that it probably does improve afferent function, but I think it's a small amount of improvement. If it were a large amount of improvement in afferent function, we'd all be doing it.
Okay, thank you. I have many questions, and two of them are from my friends, Mohamad and Samir from Jordan, and Mohamad Jaafar. Maybe we'll take them at the end. But let's proceed now with the next speaker, please. Thank you, Sean. Okay, so our next speaker is Dr. Alaa Ghannam from Beirut, Lebanon. He's a pediatric ophthalmologist and strabismologist, and also a neuro-ophthalmologist. He's a clinical instructor at the American University of Beirut and a visiting consultant in Mufid's Eye Hospital of Dubai. I'm very glad to have Alaa with us today, and he's going to give the next presentation. Alaa.
Dr. Alaa, we can't hear you.
Alaa, please unmute. Alaa, you're muted. Please unmute.
Dr. Mace is she's a neuro-ophthalmologist and a pediatric ophthalmologist and strabismus specialist at Duke Eye Center. She's also an associate professor there. Mace, we're glad to hear what you have.
Yeah, there we go.
Okay, Jamal. Okay, so one of the questions here is in nystagmus, which carries a more diagnostic yield? Would you do neuroimaging or ERG, electrophysiologic testing?
Yeah, so I think, again, it depends upon the characteristics of the nystagmus. For infantile nystagmus syndrome, so someone who presents at birth or shortly after birth with the typical nystagmus that is right beating and right gaze, left beating and left gaze, with a null position in one direction or the other, these are not going to have neuroimaging findings if the afferent visual system appears normal. So I think the yield there on an MRI is pretty low. The question there then becomes, do you do an ERG or do you do the genetic testing? And we're fortunate enough in the States to have this inherited retinal disease panel. I don't know if it's available internationally yet. Spark Therapeutics does it because they make the gene therapy for the for LCA that's caused by the RPE65 mutation, and they're trying to look for patients with it. So I think they probably have it available worldwide, but I don't know the answer. Maybe somebody who does can get on the chat and let us know. But that is such a such a nice way to get at this. And in my experience now, with about 20 of them, I think we're 70 to 80% yield in identifying the pathogenetic mutations. So that's kind of where I've gone with this, and probably over the last 3 to 5 years, that alone has revolutionized my practice more than anything else that I've done in the last half decade. Is changing that practice pattern to use that disease panel rather than ERG and neuroimaging.
Okay, that's great. Nice. Thank you, Sean. Nice. Are you ready?
I am ready.
Okay, please go ahead. I'm going to mute myself and stop the video. Please go ahead.
Okay, so thank you for having me. I already said my introductions. These are my financial disclosures. And I'm going to be talking about optic nerve abnormalities or optic neuropathy in children. So there are multiple appearances of the optic nerve. These are a few examples that you'll be able to recognize. This can be normal or pseudo-normal. Papilledema is easy to recognize, or severe optic disc edema, and I'm not going to delve into that after Dr. Heidary's excellent presentation. Optic atrophy with pallor of the optic nerve is easy to recognize. Optic nerve hypoplasia, morning glory disc, colobomas, there's multiple others. And I'm going to be talking about the not as obvious scenario whereby don't look very flagrantly abnormal, or we can't tell if they're normal or abnormal. And these can be on the form of papilledema, pseudopapilledema, or they can be in the form of a cupped pale optic nerve, but I'll concentrate more about the pseudopapilledema or papilledema looking nerve. So whenever we're talking about papilledema, there's grades. And for grades 1 and 2, we don't have vessel obscuration. Grades 3 to 5, we start having vessel obscuration and margin changes. And what makes a difference between 2 and 3, that little vessel obscuration makes a difference with the risk of vision loss, but also makes a difference is that pseudopapilledema can look a lot like grade 1 and 2 papilledema. And grade 3 and 4, we don't really need any fancy extra imaging to tell them apart, but it's the 1 and 2 that are difficult to distinguish. So I'm going to start with a case. This is a prepubertal 11-year-old girl who is overweight but otherwise healthy. Was complaining of headaches. Her pediatrician got some neuroimaging, which showed cerebellar tonsillar herniation. She was seen already by a neurosurgeon who said, well, there's enough flow through that, so this is not a decompressible Chiari. Let's just have you get an eye exam. This is her vision, and anterior segment and refraction are unremarkable, and this is her fundus image. So basically, she had bilateral 360-degree elevation of both optic nerves with blurring of the disc margins and no vessel obscuration, and I wasn't convinced I could see spontaneous venous pulsations. So for me, this is either pseudopapilledema or true papilledema. I got a visual field. There may be some enlarged blind spot over here. And here's a laser. So there may be some enlarged blind spot. And these are not very reliable visual fields, but it wasn't convincing that I could tell a difference based on these visual fields, whether it's true papilledema versus pseudopapilledema, since both of them can also get visual field deficits. So we got an OCT and we corrected the segmentation errors, so I spared you that. And after we corrected the segmentation errors, we noticed two things. One, there's an opacity underneath the nerve, which doesn't tell me much. And that the retinal nerve fiber layer was 202 and 203, which is quite high for what's expected out of her refraction and age. We got a scan through the optic nerve. So there's two ways you can do the scan through the optic nerve. The EDI is enhanced depth imaging, and you can image the deeper layers better. And if you're looking to characterize the opacity underneath the optic nerve, you really need an EDI. But this scan is already telling us something, and that is, if you look at the orientation of the Brooks membrane, it's bowed upward, and it's not supposed to be bowed upward. It's supposed to be flat or bowed backwards. So two things we get from the scan. First, her Brooks membrane opening. So this opening here was a little large. And two, there's upward bowing of the Brooks membrane. And this is actually my favorite scan to evaluate optic neuropathies. And the reason this scan is my favorite is a lot of time I don't have the luxury to get the full complete scan. So this is the macular scan. And what it tells me is that I can look at the ganglion cell layer over here. And easy way to orient myself is I find the inner nuclear layer, and the ganglion cell layer is supposed to be about 1.5 times the size of the inner nuclear layer. If the ganglion cell layer is healthy, then I know I don't have vision loss, which is a very highly valuable information, especially when I cannot get a visual field. And if we map out the ganglion cell layer, we get a ganglion cell layer map. In this case, she measured 1.16 and 1.14, which is quite reassuring to be normal for her age. We got autofluorescence. There was no abnormal autofluorescence, but that doesn't rule out pseudopapilledema. We got a fluorescein angiogram. She had a little telangiectatic vessel that was present early and late, but there was no leakage out of that optic nerve. So she got a lumbar puncture. Her intracranial pressure was 30, which is a little high, and she had a normal CSF composition. And then we put her on Diamox, and about 12 weeks after the lumbar puncture and the Diamox, looking at the fundus photos, I cannot convincingly say that she's changed. But if I look at the OCT, her retinal nerve fiber layer dropped to 167 and 172, which is quite decreased from her baseline. And her headaches were a lot better. So, and if we look at the Brook membrane position, the upward bowing was much improved on the right, not as much on the left, but it is different. And eventually her final diagnosis was a combination of both true and pseudopapilledema. So I'm going to quote Dr. Heidary here. There's no one single modality that will help us distinguish papilledema versus pseudopapilledema in 100% of the time. Thus, the importance for the clinical care, the whole clinical picture, and the importance of follow-up. So moving on, this is a case that was a little painful to me. So this is a 9-year-old girl who has a shunt. She has spina bifida. She comes in complaining of decreased vision, and she has some behavioral changes. Her testing on the vision was variable between 2100 and 2800. She was not complaining of headaches. This is her fundus photo, which was thought to be normal. Her retinal nerve fiber layer average was 98, but there was some temporal thinning. And they actually obtained an OCT of the macula on that day. And if we look at the OCT of the macula, it was called normal. But if you look at the INL and then you look at the TCL, you see that the TCL is very severely attenuated, which should not be the case. She had an MRI, which was called not different from her baseline by the neuroradiologist. And I wasn't the one seeing her at the time. And I didn't see her till 6 months later. Came out that she had shunt failure with dilation of the third ventricle. By the time I saw her, her vision was 1/800. So this was a case of both papilledema superimposed on atrophy, and it was very difficult to tell them apart. Here's another case that was sent for papilledema. It's a healthy 8-year-old boy who was noted to have an abnormal optic nerve on endoscopy for a routine eye exam. I initially thought when I looked at it, maybe it's a form first of morning glory, but when we got the OCT through it, you can see this opacity here, and there's no excavation of the nerve itself. So this was actually a Bergsmeister's papilla. Here's a typical case of optic nerve hypoplasia, very much like those cases Dr. Donahue was talking about. So I'm seeing her at the age of 6 months, but at the age of 2 months, she had roving eye movement. She had jaundice at birth that was very resistant to treatment. And
Can you make sure she's centered? Sorry, I'm not good.
she was diagnosed with hypopituitarism after her nystagmus was developed, and treating the TSH and ACTH deficiency helped the jaundice. So these were her optic nerves. So this is a very obvious case of optic nerve hypoplasia. You can see the nerve is very, very small. There's barely any rim tissue. There's anomalous branching of the vessels. So one thing to remember about optic nerve hypoplasia is make sure you work with an endocrinologist. They do need an MRI to rule out other congenital abnormalities. And a lot of them get hypothalamic dysfunction that the parents don't get warned about. So a lot of times it's the eye doctor who's telling them, hey, they may have heat, cold intolerance, and other hypothalamic dysfunction signs. So this is so the next case I'm showing you after the optic nerve hypoplasia case, this is a 13-year-old girl who was referred for optic nerve head swelling, anomalous optic nerves. Her past medical history, she's a twin, slightly premature. She was always smaller in size from her sister, but otherwise she's been growing normally. And about 2 years ago, she's been complaining of fatigue and she's being treated for chronic Lyme disease. Her vision is 20/20, color vision is 10 out of 10, and they may have been a left subtle RAPD. And these are her visual fields. She had a little bit of a change on the left eye. And these are her optic nerves. So both optic nerves are tilted, nasally elevated, and the left one looks more elevated than the right. And if you look carefully at these blood vessels, there is anomalous branching of the vessels. We got an OCT. Her RNFL on the right was flat out normal, and on the left, she was in the 40s. That was a very thin RNFL. And the ganglion cell layer and the optic nerve on the right were normal. This is the left scan. When I measured the Brook membrane opening, she was 1046 on the left versus she was 1450 on the right. And the ganglion cell layer was slightly thin, but not completely attenuated, and she had persistence of the inner layers over the foveal center. So we diagnosed her with a mild form of optic nerve hypoplasia in case she came out to have TSH deficiency. So we treated her for hypothyroidism, and her Lyme disease resolved. So in conclusion, for anomalous optic nerves, it's important to assess the function and the structures, and sometimes the diagnosis is not obvious on the first examination, and thus the importance of documenting functional and structural status at baseline and on follow-up. OCT, particularly the central macular scan, is highly useful in assessing baseline structure and is an excellent tool for follow-up over time. With that, I say thank you.
Thank you very much. Nice. It's an excellent presentation. We really learned a lot from that. And you tackled an issue which is really difficult, how to differentiate between pseudo and true papilledema. A question to you related to the presentation that Gena had. If you have a patient with optic nerve swelling, let's say due to idiopathic intracranial hypertension, patient is on treatment, and the RNFL, the optic nerve RNFL, is decreasing, which is great. The patient is responding. At what point can you differentiate between improvement of the papilledema and the occurrence of optic atrophy? Is there any room there for macular OCT to figure out what's happening? Are we still losing optic nerve function, or is it just the resolution of the papilledema?
So this is a very good question that made me lose sleep for a few years in my life. So before we had the macular scan, and if you have a young child whereby you really cannot segment the macula, the first thing to go by, is that if you're developing optic atrophy, you are going to develop a visual dysfunction. So you're going to have vision loss. So in the adults, the way we go to say, yes, they're developing atrophy on top of edema, we go by the visual fields. Versus if you don't have the luxury of a visual field, I actually follow the macular map. And you can tell on the macular map that you've developed optic atrophy. The one caveat in that is that if you've had the injury and you're seeing, let's say you had the injury on day one that is causing the optic atrophy, and you got the OCT on day one, you will see your patient 4 weeks later, and despite the fact that the vision hasn't changed, the ganglion cell map is going to decrease, and then you'll find yourself in a situation whereby you think that atrophy has occurred in the past 3 weeks, while actually it had the onset of the problem had occurred too soon before you could see it on your first scan. So what I follow is both the visual field and on the macular map.
So the OCT is really not much more helpful than our fundus examination and looking for pallor of the optic nerve, you're saying? Because pallor of the optic nerve takes time to show, even though the injury has already occurred several weeks or a couple of months.
The OCT is super helpful. You'll see the ganglion cell loss within 2 to 3 weeks from onset, and sometimes it doesn't show on the OCT. So I actually had a case, if you want me to share it, I was worried that I'm going to go over time. It was a case of someone who's coming in with a nerve definitely not looking pale, but the ganglion cell loss, and it was early LHON. So the OCT macular map can tell you a lot about optic atrophy. It just does not necessarily time frame it correctly for you. When you get the ganglion cell loss, you know that the injury or whatever insult caused the optic atrophy happened about 2 to 3 weeks prior, but that's it.
Thank you. Thank you. That's really very helpful. For the sake of time, I'm going to ask Dr. Ghannam to try and connect with us if you can. Very good. Jamal, would you want to take over?
No, I just want to make sure Alaa is heard by everyone.
Okay, go ahead, Alaa.
For this glitch and thank you, Dr. Bleik and Dr. Jaafar and Amma for having me today. I'll be talking about pediatric optic neuritis, and I have no conflict of interest related to this presentation. I will start with a simple case of a 14-year-old female. She presented to me with decreased vision in her left eye, pain upon her eye movement, and she had that was progressive over 3 days. So her review of system was positive for a recent COVID-19 infection. And her eye exam showed a vision of 20/20 in the right eye and 20/60 in the left eye.
Okay, so it seems that we lost Alaa again. So Mohamad, can we have a couple of questions?
Go ahead, Jamal. Let's go ahead with the questions and then.
Okay. I have several questions to Dr. Donahue about medical treatment of infantile nystagmus, and specifically Esopt has been mentioned in 2 questions.
Mentioned that's intended for me. I'm not aware of using Esopt for treatment to blunt the nystagmus. May well be there, but I'm unaware of any trials for it. The problem with a lot of the different putative treatments, and there have been stem cell therapy in China for optic nerve hypoplasia and other things. The problem with all of those is that the natural history of infantile nystagmus is that the amplitude decreases with time. And so anything done, parents will see that over 6 months or a year, the amplitude of the nystagmus decreases, and they're likely to think that that is due to the treatment that was prescribed, when in fact it's just the natural history. These are really hard studies to set up because you need an endpoint, and visual acuity is usually relatively variable. The best thing to take is this NAFX that Rich Hurdle has done, which is a measurement of the nystagmus waveform. But most people don't have the ability to test for that. So I'm unaware of any topical pharmacologic treatments. There are some pharmacologic treatments for acquired nystagmus, like methadone and things that are oral, that are relative sedatives. Again, they don't seem to be particularly helpful, even in patients with acquired nystagmus, to help their oscillopsia.
Can you hear me now?
I hear you.
Can you hear me?
Yes, go ahead.
Can you move the slides, please, forward? There's a problem with I cannot share my slides. Can you move the slides forward, please? More forward. Yes, please. Again. So more. So the pediatric optic neuritis is different than adult optic neuritis, and we can start with the etiology. And a lot of the pediatric optic neuritis can be monophasic, happening once post-viral infection or post-immunization, or even it can be idiopathic. Again, move forward, please. Or it can be also the recurrent optic neuritis. Idiopathic optic neuritis is rare in kids, but but optic neuritis can be. But the optic neuritis can be also related to systemic illnesses or diseases. If you can move forward. Like demyelinating diseases or autoimmune diseases or even infections. Forward. So the symptoms of pediatric optic neuritis can be different among kids, and it's not uncommon to have bilateral optic neuritis, especially in kids less than 10 years of age. But it is usually unilateral in kids more than 10 years of age, and we go back to prepubertal versus postpubertal. Pain is not consistent among kids, and pain can range between 33 to 70% of kids with optic neuritis. But you have to remember that kids can have difficulty in expressing their pain, or can have difficulty in distinguishing pain from headaches. Decreased vision is always present, and if we can move forward, we can see that decreased vision is worse usually than adults. Only 20% of kids that present with optic neuritis have vision acuity of 20/40, better than 20/40, while 60% will have vision acuity worse than 20/200. However, recovery is usually the rule in more than 90% of the cases. Visual field defect is also almost always present, and also we can see contrast sensitivity deficit as well as color vision deficit. If we can move forward, yes, again. Okay. So, and also if you have a unilateral disease, you will find an afferent pupillary defect. Forward, please. Yeah, again, forward. And you can see also an optic nerve swelling acutely in up to 70% of the cases. And this is in contrast to what we see in adults. And according to the optic neuritis treatment trial, only 30% of adults will have optic nerve swelling or papillitis. Later, you will have optic nerve pallor. And if you are faced with a patient with optic neuritis, you have always to think of other causes of optic nerve swelling or decrease in vision, and look for unusual signs in kids like retinitis or uveitis, or severe nerve pallor, or absence of recovery after steroids, or absence of enhancement of the MRI, absence of pain upon eye movement, or presence of other neurological signs, or presence of headache, nausea, and vomiting, and tinnitus. And you have to look for other causes of the symptoms. And if you can move forward, you can see the differential diagnosis that include neuroretinitis, papilledema, compressive, inherited optic nerves, ischemic, rare in children, toxic, nutritional, and even functional. Can move forward, please. So, when we have a kid with optic neuritis, the first thing to do is an MRI brain and orbit with and without gadolinium to look at the optic nerve to see that enhancement of the optic nerve. And if you see a longitudinal enhancement of the optic nerve, you have to think of neuromyelitis optica or anti-MOG disease. You can also do a lumbar puncture looking for oligoclonal bands, and also look for signs of meningitis, and you can do a blood workup for secondary causes of optic neuritis. You can move next, please. And so the most common causes of optic neuritis in kids are post-infectious or post-vaccine, and these are more common in children than adults. And it's actually an autoimmune reaction rather than an infectious process. And a lot of viruses and bacteria have been reported to cause optic neuritis, and of relevance to us during this time and age would be COVID-19. Some reports came out of relating COVID-19 to optic neuritis, and there's a lot of vaccines also that can cause optic neuritis. Next, we can see that also multiple sclerosis, we know that it has been historically associated with optic neuritis, and actually optic neuritis is the initial presentation of multiple sclerosis in 10 to 22% of pediatric multiple sclerosis. And actually also the incidence of multiple sclerosis is rare in children. And the McDonald criteria that we use to diagnose MS in adults is less accurate in children less than 12. So if a kid comes to you with a optic neuritis and asks what is the chance that this kid will develop multiple sclerosis later on, it's not well studied in children, and the number ranges between 13 to 36%. And the percentage is higher if there is any white matter lesions on the brain, and if the age of the presentation of the kid is older, so more like a teenager, and if there's any oligoclonal bands on the lumbar puncture. Next disease is acute disseminated encephalomyelitis, or ADEM, and we know this is a disease that's specific to kids with multifocal acute demyelinating syndrome. Kids usually present with fever, encephalopathy, seizures, and usually the MRI will show T2 lesions, but they are not periventricular and they are of the same age, unlike what we see in multiple sclerosis. Another disease would be neuromyelitis optica, which is a devastating disease causing demyelinating attacks affecting the spinal cord or the optic nerve. And the pediatric neuromyelitis optica usually constitute around 4 to 7% of all neuromyelitis optica. You can find positive aquaporin 4 antibodies in the blood and the CSF. And on the MRI, you can see a longitudinally enhancing optic nerve and sometimes optic chiasmal enhancement. And usually you get a more severe and persistent vision loss and poor visual recovery, as well as thinning on the retinal nerve fiber layer. The relatively new kid on the block, the anti-MOG antibodies, and now it has been diagnosed as an independent causal mechanism of optic neuritis. The kids were usually before diagnosed with NMO or ADEM or CRYON and ended up having positive anti-MOG antibodies. Also, you will see longitudinally extensive lesions along the optic tract and the perineural enhancement. And usually you will get also swelling of the optic nerve with some hemorrhages around the optic nerve. And of all the patients with anti-MOG disease, around 1/3 of them are actually kids below the age of 18, and they respond beautifully to steroids. Next, please. So the treatment of optic neuritis, also there's no clinical trials that have been successful, but we follow the optic neuritis treatment trial and we give steroids for 5 days. We know that steroids will not change the end result of pediatric optic neuritis, but it will fasten the recovery. And this is important in children because you want to shorten disability in school and improve the crucial daily visual function. And if you have a unilateral optic neuritis in a kid less than 8 years of age, you want to prevent amblyopia by giving steroids. And what if steroids fail? Limited data as well, but you can give plasma exchange, immunoadsorption, or IVIG. And now that I talked a little bit about pediatric optic neuritis, I will mention few cases that were referred to me as a diagnosis of pediatric optic neuritis. First, I have a 12-year-old girl presenting with headaches, diplopia, and decrease in vision. Past medical history is negative. Move forward, please. And you can see her vision is 2400 in the right eye and 2200 in the left eye with decreased color vision. Forward. The fundus exam shows mild swelling of the optic nerve, and the MRI shows longitudinally enhancing bilateral optic nerves as well as enhancement of the optic chiasm. There was also a lesion in the pons I didn't show, but this girl was diagnosed with NMO. She was started on steroids and her vision recovered. Next. Case 2 is an 8-year-old girl referred for bilateral progressive decrease in vision for the past few months. She had no pain and her past medical history is negative. The review of system was only positive for headaches. Next. She had a vision acuity of counting finger near face in the right eye and 2200 in the left with decreased color vision. Next. The OCT shows a severe RNFL thinning, as you can see here. And we can see also on the MRI, next, that there is enhancement and thickening of the optic chiasm with also enhancement of the hypothalamus and the pituitary stalk. Next.
Alaa, please wrap up.
Yes. So let me finish this case. Next again, please. So the workup was negative. So red flags for this. This patient was treated with steroids and did not respond, as well as IVIG. And red flags in this back, please. And the red flags in this case was progressive decrease in vision, absence of pain, and she did not respond to steroids and IVIG, as well as thickening of the optic chiasm, hypothalamus, and the pituitary stalk. Next. So our diagnosis was optic nerve glioma. She started on radiotherapy, vision partially improved. She developed diabetes insipidus and panhypopituitarism. Her vision deteriorated again. An MRI was taken and it showed a pineal tumor, and the biopsy of pineal gland showed a germ cell tumor. We can move forward, please, till the end. We can skip these, and we can skip that as well, please. And we can talk a little bit about to wrap up, we can move forward again. I will have to say in conclusion that pediatric optic neuritis is different than adults. Back, please. Especially in pre-pubertal years. Full recovery is usually the rule, and risk of developing demyelinating disease is unknown, but you have always to look for red flags to rule out other causes. And thank you for having me again, and sorry for this glitch that happened.
Thank you very much, Alaa. That's really a very nice summary of optic neuritis in children, and you highlighted very good points, so we do appreciate that. We are all sorry for the technical glitches. Unfortunately, they do happen, especially I think Dr. Ghannam had some issues with the electricity and the connection of the internet. Thank you again. At this moment, I would like to move along, and again, I didn't have, because of the glitches and so on, I didn't have the opportunity to properly introduce Dr. Jane Edmond, As most of us know, Jane is professor and chair of the Department of Ophthalmology and director of the Mitchell and Shannon Wong Eye Institute. She is the Wong Family Distinguished University Chair at the Dell Medical School at the University of Texas at Austin. And she had many positions at IPOSC and the American Academy of Ophthalmology, and she is the immediate past president of IPOSC. So thank you, Jane, and thank you all for your participation. And I would like to move along, leaving you with this picture of Beirut downtown. Hopefully, we will be able to host you all in Lebanon soon. I cannot thank enough all the speakers, Dr. Edmond, Dr. Donahue, Dr. Heidary, Dr. Dairi, as well as Dr. Ghannam. I would like to thank the LAU and its staff, Lama Naeem, Dr. Avirad, the head of the CME program at the LAU, IPOSC, is represented by Drs. Orge and the past president, Dr. Sunan Farzabandi. Miyako, represented by Dr. Abdulaziz Badla, and Dr. Mulki has been very influential. I also would like to thank the Lebanese Ophthalmology Society. And at the very end, I would like to have Dr. Jason Yam, who is the chair of the education committee at IPOSC, to give us the last words, as well as mention the next webinar that IPOSC is hosting. Yeah.
Thank you, Dr. Jaafar and Dr. Bleik. I would like to congratulate you all for the wonderful webinar we have just now. And looking forward to the IPOSC joint webinar next month. I would like to ask our audience to mark Canada. It will be July 11th, a Sunday on 8 a.m. EDT time. The topic this time is Hypertension Strabismus with Taiwan colleagues. This time is with the Taiwan Pediatric Ophthalmology and Strabismus Society. We are very honored that to have Rosario Gena from Spain, Dr. Comitant to be the moderator. We will talk about the pros and pitfalls in diagnosis of Hypertension Strabismus by Dr. Wang Angguo from Taiwan, surgical management of such policy by Phil Adams from UK, and the effect of modified grade recession and gestation and myopathy of IO in SO policy by Wei Yu from Taiwan. And from one month of surgery is not enough in SO policy by Andrea Moderelli from Africa. And also some aspect of paralytic system policy by Anthony Murray from South Africa, and management abuse policy from in Taiwan. So I look forward to you all to join the webinar for next month in July 11 for the joint IPOSC webinar.
Thank you, Dr. Yam. I should mention that this webinar has been recorded and will be posted both on the web links of the Lebanese American University as well as IPOSC. Give us a week and you can access the webinars, and we will also try and have answers to the questions that we could not answer. Again, on behalf of IPOSC and the LAU, thank you for attending, and we look forward to more webinars and more interaction with our audience worldwide. Thank you all. That will end our meeting.